Thank you. So this is a very important topic that we have not touched for some time. That's why I thought of giving this talk. So each time when you examine a premature baby, remember you are screening a child for a cause of very important cause of preventable childhood blindness. So if you screen properly, diagnose properly, and then you can if you can arrive at a diagnosis properly, then you are essentially preventing a very important cause of childhood blindness. So this picture, retinal photograph, is a very memorable picture for me. It is the first picture taken out of a Sri Lankan child in a red cam, and it was the start of telemedicine for ROP in Colombo. The infants, the fetus lives in mother's utero in a very hypoxic, relatively hypoxic state. As you can see, the arterial tension is about 40 to 50 millimeters of mercury. What happens when the child is born, when the baby is born, the premature delivery triggers upregulation of the oxygen. We deliver a lot of oxygen to save baby's life, but it essentially downregulates VEGF in the developing retina. So that creates relatively hypoxic environment in the peripheral retina, and that is the start of demarcation and the peripheral avascular zone. So that leads to the peripheral ischemic area leads to increased VEGF secretion, and then the cascade of proliferation and traction starts on. So a few stats from LRH. Over 2.5 years, I have seen about 1,000 babies, of whom I have diagnosed significant ROP in 228. That is about 20%. So remember, these are a bit overestimated diagnosis, because most babies are referred, about 30% are referred directly for treatment from other hospitals. So we have, how we have managed is that we have, so I'm managing the more posterior severe diseases with Beucosibep. I preserve laser for cases with traction and more anterior disease. Of course, there are few cases which need more invasive intervention, like retinal surgery, but essentially most cases we can manage in our setup with very good outcome. So important characteristics of these babies who develop severe ROP include that they are born around 28 weeks, 29 weeks. So remember, very infants, either they don't live up to the age that they get ROP, or they develop milder ROP and then resolve spontaneously. Very older infants in Sri Lanka, they don't develop this severe ROP, but they develop mild ROP, which needs probably non-treatment. Their birth weight is about just about 1,000 grams, and this is the most important finding. Mean POA at treatment is about 34 weeks, between 32 and 35. So remember, they don't get ROP before 31 weeks. So there's no point seeing babies before 31 weeks. Even though they get ROP, very mild forms of ROP, we don't treat. So we are not doing this very invasive procedure just to diagnose milder forms of ROP, but to diagnose severe ROP, which requires treatment. When we go for international meetings for ROP, they talk about artificial intelligence, newer medicine, telemedicine, and all that. But old-fashioned way is the standard, still standard. Your examination with indirect ophthalmoscopy, 20D lens or 28D lens, and documenting your findings and referring the patient early. So international classification of retinopathy of premature, the third edition was out for now a couple of years. They have emphasized on a few areas, particularly they have redefined some areas in zone, and they have renamed APROP as AROP. And they have emphasized particularly on regression patterns, reactivation, and long-term outcome as well. So as we know, there are 3 zones, but now according to the latest classification, there are 4 zones. They have included the posterior zone 2 as a proper zone in ROP classification. So posterior zone 2 is just a suburb of zone 1, 2 disc diameter area around zone 1. And often we see this notch when we examine very sick babies. The main ridge is in a more peripheral zone, but there is a notch coming through about 1 or 2 clock hours into more posterior zones. So this is called a notch. So this is essentially zone 1 ROP, which is caused by the notch. And you have to treat it like a zone 1 ROP. Plus disease, recognizing plus disease is very important. This indicates the severity of the disease, as well as it guides us for treatment. So arterial tortuosity and venous dilatation is very important to recognize. Then pre-plus disease is defined as arterial tortuosity and venous dilatation inadequate to name as plus disease. So the first few pictures, so these are examples for plus disease gradually increasing up to proper plus disease. So often when we screen these babies, we see the end of blood vessels. When blood vessel grows and ends somewhere there. Beyond that, it's a avascular zone, but there's no demarcation line or anything. So in this sort of situation, what we do is we document as vascularizing zone 2. But according to the latest classification, you better use the word incomplete vascularization into zone 2. So that is a nomenclature they are proposing in ICROP 3. So stage 1 is a demarcation line between the vascular and avascular regions. And it's not a 3-dimensional structure, but it converts into a 3-dimensional structure if it develops into a ridge. That is stage 2. So when you screen, gradually you can see these changes. So in bit more advanced cases of stage 2, you can see the so-called popcorns. They are extraretinal vasoproliferation, the start of extraretinal vasoproliferation attempts. So that is popcorns, and finally the stage 3 appears. That is the proper extraretinal neovascularization, which leads to the proper ridge. So note this in this picture, there's plus disease as well. So this child needs urgent treatment. So APROP is renamed as AROP because not in Sri Lanka, but we have seen always in posterior diseases, but in other countries where the facilities are not very good, the neonatal facilities are not good, they might develop this very aggressive ROP, not essentially in posterior zones, maybe in more anterior zones as well. So they have removed posterior part, but still the same thing. Very aggressive ROP, which do not respect the normal progression of ROP from stage 1 to stage 2 like that. So it will straight jump into stage 3 all of a sudden within few days. So regression patterns, I didn't include the retinal detachment in this discussion because it's out of this discussion. So regression patterns is very important to identify these regression patterns. Once we treat, most probably this patient we would treat with intravitreal bevacizumab. What happens is the changes dissolve, they disappear gradually. And the physiological vascularization restart after some time. So it's very important to identify this. Earlier we used to laser these kids, but now we don't. Because we don't give the side effects of laser for these kids. But remember, if you don't laser, you have to see them until the retinal vasculature reaches the temporal ora serrata. So signs of regression, even on day 1 after bevacizumab injection, you can see decreased plus disease. And sometimes in most occasions we can see dilatation of the veins becomes less. Tortuosity may become a little bit it takes a little bit longer to disappear. And after a few days, vascularization starts in the more peripheral retina. Pupils start dilating if the pupil was not dilating earlier. And the media clarity improves, the vitreous and the lens clarity improves. Of course, other changes also will reverse. With the invent of bevacizumab treatment, there is another problem coming up. There is the persistent avascular retina, the OPA area in peripheral retina. Once we treat, we continue examining the baby until the vascularization complete. But in certain babies, it does not. However much we examine, how longer we examine, there is always a avascular area. What I do is, after 63 weeks of postmenstrual age, I laser them. Reactivation can happen. It's very important to identify and treat accordingly. So these ROP babies can have long-term sequelae. They can have refractive errors. They can have squints more often than other babies in the same cohort. But they can have late retinal changes. Sometimes if they have remaining traction, they can have retinoschisis. This persistent avascular retina is a problem because we can't keep on examining these almost toddlers in the same way we used to examine when they were babies. So they can get foveal hyperplasia, and they can get retinal traction later on, and glaucoma is an important thing. So these babies we can't diagnose, we can't discharge from our setup. So we have to keep on examining them. As some summary, remember, severe ROP does not occur earlier than 32 weeks. So if you examine the baby at 31 weeks, that should be fine. So of course you have to refer timely, and these children has to be followed up long term. And it's important to explain this to parents or mother who carry the child to the clinic. You have to take your time and explain why they should come back for follow-up. So this is my last slide. I took this from the Royal College guideline. So we are always baffled when to see the baby first. So I suggest we all start seeing babies when we go to the neonatal ICU. We can tell them, any baby born before 27 weeks, please refer at 31 weeks. So you are not bothered about developing ROP before 31 weeks. Any baby born after 27 weeks, please refer at 3 to 4 weeks post-menstrual age. So that simplifies your follow-up. Otherwise, with this complex sentence, we all have baffled our neonatologists, so they are a little bit in a complex scenario when to refer for the first time. This is what I follow in my private sector, so they are not baffled. So I think I suggest that we can all adapt to this. This is from Royal College guideline. Okay, thank you very much.